Increasing Mobility on Med-Surg Floors at Montefiore St. Luke's Cornwall, NBC 494 RN Leadership Synthesis Project by Lisa Gagan. Introduction. Montefiore St. Luke's Cornwall does not have a bedside mobility assessment protocol. Nurses are expected to assess their patients' mobility needs and evaluate those needs against the physician's order and the physical therapy department recommendations without the use of an evidence-based protocol or tool. While a fall risk assessment tool exists to help nurses, the same standard is not met with bedside mobility. Physician orders for mobility requirements are often outdated and do not match up with the physical therapy department recommendations. According to data from 2018 at MSLC, 45% of the patients over the age of 5 who were discharged from the med-surg units needed some sort of physical therapy. 15% needed outpatient physical therapy in the form of in-home therapy appointments, while 30% needed inpatient rehab with follow-up physical therapy appointments. Not only that, but length of stay averages in MSLC were greater than a day when compared to the national U.S. average of 4.5. MSLC's average is 5.5. Lack of mobility in the hospital setting leads to increased lengths of stay, higher risk for falls, increase in pressure injuries. Readmission rates for the patients are greater than 50%, and often readmissions are related to mobility and injuries from falls. Research shows that a lack of standardized protocol for daily mobility goals leads to a lack of success in decreasing these numbers. A team of 5 was created to advertise this project and see it through completion. As nurse managers of the 2 med-surg units at Montefiore St. Luke's Cornwall, Kristen Prince, MSN BSN RN of 3 North, and Bonnie Heal, MSN BSN RN of 5 North, would be the main leaders for this project. Rosa, working as a resource and a mentor, 4 North nurse manager, and Alexis and I would be the ones generating the PDSC cycles data to compare to that of the data collected from 2018 to evaluate our change. Other members of the interdisciplinary team that were included in this project were members of dietary, physical therapy, physicians, PCAs, members of administration, and the education department, as well as the other nurses in the unit and PCAs. The specific aim. The specific aim of our project is improving mobility and decreased length of stay through the implementation of a nurse-driven ambulation protocol. PDSA cycle, Plan, Do, Study, Act. In order to enact change, we came up with a PDSA cycle. Our goal is to decrease the length of stay and readmissions in patients 65 and older by focusing on improving mobility through a protocol that includes a bedside mobility assessment tool, BMAT, and a standardized number of how many times a patient should be ambulated per shift. Alexis will be conducting the research and project on 5 North, while I will be doing it on 3 North. We will evaluate the change by conducting interviews with various members of the disciplinary team to evaluate their feelings on the project's pros and cons, as well as looking at the data we collect and compare it to that of 2018. Then, when we have determined an effective evidence-based practice protocol, we will go to value analysis and have it standardized across the hospital. Steps to change. A bedside mobility assessment tool was chosen by the team in order to carry out this project. Myself and Alexis were tasked with doing this daily assessment tool every day with our patients in order to identify a BMAT score, which would then determine their mobility needs. Each day we came into work, we would assess our patients' mobility needs with this tool by completing the tasks designated in every level. We did not refer to the patient score from the previous shift or day, thereby creating our own assessment and judgment. By using this sheet that stayed with the patient, we were able to track the patient's mobility needs day to day and see an upward trend in their mobility. At the end of the shift, we will record our BMAT score, fall risk score, and how many times the patient ambulated in a binder at the front desk in order to track the data. Whenever a patient that was included in the project was discharged, we would record their discharge instructions, whether they needed outpatient physical therapy or at-home physical therapy. For this project, we chose only patients that were 65 and older and did not need physical therapy prior to the project. Each nurse was educated about the project so that they were given handoff on a patient who was included, they would continue on and record their scores. The BMAT scores is in levels. A patient would pass or fail each level in order to determine the safest way of ambulation. The first level is a complete assist, which would require the use of a mechanical lift such as a Hoyer. The second level is partial weight bearing, such as the use of a sit-to-stand machine to help with transfers. The third level is the requirement of assistant device of some sort, such as a walker or a cane, and typically involves 2 people for assistance. The last level is minimal or one assist, which may or may not require the use of an assistive device such as a walker. Each patient is assessed and given a level score for the day that would help the nurses to fulfill their ambulation requirements. Along with this BMAT tool, each patient would be ambulated at least twice per shift as per their ambulation/mobility needs. If a patient was able to walk, they would be walked in the hallway. If they were not, they were ambulated from their bed, and basic physical therapy tools were used, such as moving their arms and legs to help gain strength. Implementation of change. In order to gauge the effectiveness of this project, the team met in person or virtually every week to discuss our findings. We shared information between each other such as the struggles of implementing this tool during a pandemic, being able to do the assessment accurately at the night shift with patients that might be, quote, sundowning, and handed out surveys to gauge attitudes. Some of the feedback we received included lack of communication between nurses and PCA's mobility needs, for example, not filling out mobility boards or not giving accurate reports, incorrect physician orders, for example, a physician writing bed rest for 24 hours but nothing ordered for following that, complaints of not having enough time in the day, or the classic more paperwork. Really? As the project went on and more nurses became engaged and started seeing the positive effects of the BMAT tool and ambulating patients, for example, less falls and less, quote, close calls, attitudes started to shift. When nurses and PCAs were less afraid to have their patients fall, they were more attentive to their mobility leaves. Quite a few of my coworkers were shocked to discharge patients home who were well into their 80s without physical therapy. In order to get past these pitfalls and these hiccups, seeing a positive effect in our patients and less falls was a huge, huge impact. Spread the change. Education, education, education. This entire project is based on the hard work and dedication of the nurses at MSLC. Throughout the project, we educated each floor on what we were doing and provided them with copies of the bedside assessment tool to try on their patients. We slowly introduced this idea of a new way of looking at our patients' mobility needs and assessing them. By recording the data and the outcomes, we were able to not only tell our coworkers what we were doing, but we were able to show them the change. A decrease of 10% in the discharges involving physical therapy was seen, although length of stay remained about the same. We will continue to conduct more PDSA cycles as the year goes on and bring out protocols to value analysis for review. At this point, it's hard to determine if our protocols would need to be changed or if the current pandemic is negatively affecting our length of stay outcomes and cannot be changed. Summary of our impact. While we have some more positive impacts of our project thus far, there are still many barriers to work through. We currently use a Meditech system and have yet to change over to Epic, which would allow us to implement the bedside assessment tool into our computer documentation. As we move forward with our project, we will continue to evaluate how and where the nurses would be required to document the patient's BMAT score, whether that would be on a piece of paper hung in the patient's room for everyone to see and then added to the chart later at the end of the shift, or when we move to Epic, we will do it completely paperless. Overall, thanks to the hard work and dedication of our team, we were able to implement and utilize an evidence-based tool to help our patients and prevent harm. I look forward to continuing this project with my team and sharing the results with the hospital. Thanks for listening.